Hello everyone and welcome to a new session of clinical pharmacology and drug therapy. Our topic for today is about the drugs that used to treat allergic rhinitis. I am Dr. Khalid Hassan, professor of clinical pharmacology. Okay, allergic rhinitis, like a brief introduction before we start speaking about the treatment, pharmacology, medication used for allergic rhinitis. Allergic rhinitis is kind of the inflammation of mucous membrane that affect the nose, and the patient may suffer from sneezing, itchy nose, itchy eyes, and watery rhinorrhea, nasal congestions, and sometimes non-productive cough. And what happened there? We have allergens, could be any substances around around us in the environment, contact with the mucosa, and our mast cells will be responsible by release mediator. Okay, so as you can see here, we have foreign materials, and this foreign materials interact with the mast cells coated with the IgE and generated in response to the previous allergen exposure. The mast cells mediator, we have several mediators there. We need to remember all these mediators: histamine, leukotriene, chemotactic factors, bronchial spasm. This chemotactic and histamine promote bronchial spasm, promote thickening of mucosa, edema, and cellular infiltration. Most popular medication used for allergic rhinitis, antihistamine, and followed by intranasal cortisone as preferred therapy. Pathophysiology, again, the allergen contact with the mast cells, and through the IgE, this will lead to the triggering of the and release of inflammatory mediators. Again, we have initial phase, we have immediate phase, we have late phase. But for the simplicity here, we don't discuss details of the mechanism of action of the drug allergy. Here we focus on the two main phases: immediate, early phase, and late phase. But if you need more details, for example, I recommend you to review the pathophysiology of drug allergy. Okay, with the immediate reaction that requires second 2 minutes, sometimes like 60 minutes, sometimes like 90, 100 to 100 minutes, like 1 hour, 2 hours. Okay, after maybe exposure to the allergens, then the mediator will be start release from the mast cells. So we have a list of mediator. Could be histamine, as I mentioned before. Could be leukotriene, prostaglandin, tryptase, and other kinine. What happened there? The situation in the tissue and cells. We are going to see vasodilation. We are going to see increased vascular permeability. We are going to see the increased secretion of the nasal secretion. Increase the secretion of nasal from the nose. Histamine, as you can see here, involved in the producing rhinorrhea. Histamine cause itching and sneezing and nasal obstruction. All these effects related to the increased release of histamine from mast cells. Later on, after around 4 to 8 hours, cytokine will be released. At late phase of reaction, cytokine will be released. We have different type of cytokine. This will lead to the chronic inflammation and sometimes tissue damage. Okay, as you can see here from the image, from the picture here, you can see we have first of all we have the allergens in close contact with the epithelials, with the mucosa, then penetrate the mucosa. This allergen contact with the IgE on the mast cell surface, on the IgE. IgE stands for immunoglobulin E. So as you can see here, the inhaled allergen contact with the IgE. IgE, by contacting the mast cells, will trigger the granulation or degranulate the mast cells, stimulate the mast cells to release their content from histamine, from the prostaglandin, from leukotriene, tumor necrosis factor, alpha, and interleukin. Due to the release of this mediator, the patient in this early phase will start suffering from runny nose, wheezing, itchy skin, itchy red eye, itchy nose, and sneezing. In the late phase, this one like during the minutes could be like 1 minute to the 2 hours, for example. Here a late phase take sometimes weeks to see this symptoms there. What happened in the late phase of allergic rhinitis? Other cells will be activated here, as you can see. So we have eosinophil, we have basophil, we have B cells. Then we can add here T cells also. So we have a list of medication may involve in this process. Okay, we can add here T cells, and due to the activation of these cells, this will lead to the release of leukotriene, release of tumor necrosis factor, interleukin, granulocyte, histamine, leukotriene, different type of interleukin. We are not going to discuss the differences between these interleukin 1, 3, 4, 5, 6, and we have all these mediators will lead to the chronic inflammation and further tissue damage. Okay, so as you can see here, we have the mast cells. Here, and when the allergen contact with the IgE will trigger the mast cells to produce the granules, degranulation of the histamine, activate the cell membrane. The cell membrane of the mast cell will be activated through the enzyme called phospholipase A2. When the phospholipase A2 activated, this will lead to the formation of arachidonic acid, and arachidonic acid considered the main source of prostaglandin and the main source of leukotriene. So for arachidonic acid, we have two main pathways. The first pathway called cyclooxygenase, and the abbreviation for cyclooxygenase COX, cyclooxygenase, and this will lead to the formation of prostaglandin. Another one here, and the prostaglandin considered the main source of pain, inflammation, and fever. Leukotriene also, so through the pathway called lipooxygenase, and the abbreviation for lipooxygenase LOX. So we have leukotriene. Leukotriene is responsible for inflammation, responsible for the chemotaxis. Okay. Then we as you can see here, the leukotriene bind to the leukotriene receptor, and here we talk about another cells. So the mast cells here release content. Leukotriene will be activated. Leukotriene will go to the another cells called smooth muscle cells. Here we talk about non-fascicular smooth muscle cells. Okay, so here we have non-muscular smooth muscle cells. Okay, sorry, I have to repeat that. Not non-fascicular, not okay, non-fascicular smooth muscle cells will be affected by the leukotriene, and you can see here we have leukotriene receptor, and this will lead to the increased calcium and contraction. So you can see the effects here of leukotriene lead to the contraction, number one of these medication here. Another pathway, a release of histamine. This is the main source for us, releasing histamine. Histamine will bind to the H1 receptor and activate GQ and increase concentration of calcium. This will lead to the contraction of smooth, non-fascicular smooth muscle cells. Okay, so moving to this classification of hypersensitivity reactions. As you can see here, we have four main type of hypersensitivity reaction: type 1, 2, 3, and 4. For our topic today, we only focus on type 1, because type 1 mediated through the IgE. As you can see, type 1 immediate IgE response as take minutes. Some textbooks they said 60 minutes, some other 120 minutes, and some textbooks they said second. As you can see here, the IgE bind to the mast cells and lead to the degranulation and release inflammatory factors. Patient may suffer from anaphylaxis. Some patients suffer from rhinorrheas, sneezing, which watery eye, wheezing, shortness of breath. Some example here: food allergy, drug allergy, allergic rhinitis, our topic for today, asthma, another one. So all these related to the immunoglobulin IgE. We need to remember that. Okay. What happened here when the patient come to the clinic suffer from allergic rhinitis? You can see the patient may suffer from sneezing, itchy nose, itchy eye, watery rhinorrhea, nasal congestion, non-productive cough. So all these considered like symptoms of allergic rhinitis. How we can treat patient? The slide here represent something called non-pharmacological approach. For non-pharmacological approach, we recommend patients to control the environment, avoid allergen by following the, for example, if you have pollen, for pollen outdoor, mold allergy, animal allergy, dust mite, mold allergy. So all these should be followed before we move to the drug treatment. If the symptoms is alleviated and recovered, that's fine. If not, we move to the drug pharmacological treatment or immunotherapy treatment. So for example, for pollen, outdoor mold allergy, we limit outdoor activity, keep windows closed. For animal allergy, we recommend to remove pets from home. If this is not an option for us, keep pets out of the bedroom, regular vacuum and cleaning the bedroom. We have several approaches there. Okay, now we start talking about pharmacological treatment of allergic rhinitis. As you can see here, the mainstay, the main approach will be topical. So we go with the intranasal, we go with the nose drops. Okay, intranasal, we go with the intranasal spray. Could be number one antihistamine, cortisone, this is number one. We can add intranasal spray decongestant, for example. We can use anticholinergic. This is option number 2 or 3. It's not number 1. We can go with the mast cell stabilizer number 4. So we have several options. This one to improve symptoms for decongestant. So we have several approach for topical intranasal sprays. Could be antihistamine, could be cortisone. This is the first option, followed by decongestant and anticholinergic spray. Okay, so as you can see here, the mainstay of treatment will be topical intranasal spray, and this one could be antihistamine, could be cortisone, could be decongestant, and we have other options there. For oral or like systemic, we can go with the oral antihistamine. We have oral decongestant. For the cortisone, we have oral, we have injectable, depends on the severity of the case. Then we have oral loratadine, and then we at the last one we have saline nasal irrigation. So we have several approaches here for the situation. Okay, so what we have here, now in this slide here, this slide demonstrates the approach, the clinical pharmacology approach of the allergic rhinitis. As you can see in the slide here, we have the mast cells. Okay, the mast cells here, and the mast cells exposed to the allergen. Allergen bind to the IgE. You can see here, allergen bind to the IgE. This will lead to the degranulation. Okay, cell membrane will be activated, and this will lead to the activate enzyme called phospholipase A2. And as you can see here, release of histamine. So we have two main mediator will be involved. Number one, histamine will be released. Number two, activate of phospholipase A2, activate cell membrane. Okay, arachidonic acid formation. Then we have arachidonic acid formation. Then we have activation of two pathways, cyclooxygenase. Activation of cyclooxygenase lead to formation of prostaglandin. Activation of lipooxygenase lead to formation of leukotriene. Okay, next step here, as you can see from this graph here, I will go back a little bit to maybe follow the process. Histamine bind to the receptor, histamine H1 receptor. So you can see here histamine bind to the H1 receptor, histamine. Okay, then we have another mediator called adenosine. Okay, adenosine bind to the adenosine receptor through the GI protein, inhibitory protein. Okay, another receptor available on the smooth muscles. We call this one smooth muscle cells. Okay, we have another receptor called beta adrenergic receptor here. And we have muscarinic receptor. So we have this our target. We have histamine, we have muscarinic, we have beta receptor. What else? We have leukotriene receptor. Okay, now we start talking medication. Now we are talking medication. I will go back a little bit. We need you to remember what we have here. We have histamine receptor on the smooth muscle cells. We have leukotriene receptor. We have muscarinic receptor. We have beta 2 receptor. And what else? We have adenosine receptor. We have BDF, stand for phosphodiesterase. So all these receptors available on the effector and the effector cells, smooth muscle cells. I will repeat it. We have histamine receptor, leukotriene, muscarinic, beta 2 adrenergic, phosphodiesterase, adenosine receptor. Now we start talking medication. The first group of medication used for allergic rhinitis or for allergy will be antihistamine. So the first group of medication will be antihistamine. How antihistamine work? So as you can see here, antihistamine block the bind and block the histamine receptor. Block and bind to the histamine receptor 1 and block histamine receptor. The second group of medication, this is number 1. The second group of medication here, if you go back a little bit, okay, I will clean this one. Okay, this is the first group, antihistamine, binding to the H1 receptor, block the receptor. The second group of medication will be cortisone. How the corticosteroid work, cortisone or corticosteroid work? Corticosteroid inhibit enzyme called phospholipase A2. So this is the mechanism of action. How the cortisone work? Inhibit enzyme called phospholipase A2, the second group of medication. Okay, the third group of medication will be anti-leukotriene. Anti-leukotriene, we have two main groups. We have number 1, we have xylitol, and the xylitol inhibit the enzyme called lipooxygenase. This is number 1. Okay, what else? Okay, so another one here, if you look what we have number 3, we have another number 3 here. Number 4, we have thiophyllene. Thiophyllene work on dual mechanism by inhibit adenosine receptor and inhibit phosphodiesterase. So it's two mechanism, inhibit adenosine receptor and inhibit phosphodiesterase. Two mechanisms for the thiophyllene. Then we have selective. They said we don't need to inhibit adenosine. We have another medication called roflumilast. Roflumilast, this medication inhibits phosphodiesterase, as you can see here. So roflumilast inhibit only the phosphodiesterase. Thiophyllene and roflumilast, both medication used for patients suffering from asthma. It's not for allergic rhinitis. Okay. Another group of medication we are familiar with, we have beta 2 adrenergic agonist. This medication activate beta receptor. Okay. Then we have muscarinic antagonist. Muscarinic antagonist, for example, here we can type here Ipratropium Here for this one here we have albuterol. Okay, belong to the group number 3 here, belong to the group number 3. As you can see, we have a leukotriene, LT, leukotriene receptor antagonist. We have montelukast, zafirlukast. So for anti-leukotriene drugs, we have two medication. First group of medication, we have Zolitone. Zolitone inhibit lipooxygenase. Zolitone inhibit lipooxygenase. The next group will be block the leukotriene receptor, and you can see it here. So the next group of medication will be blocking leukotriene receptor, and we have montelukast, zafirlukast. All these medication will be covered in the next coming slide. So this slide here maybe summarize the information for us how to approach patient suffer from allergy like asthma, like dermatitis, or allergic rhinitis. So you can see here the main target for us, we need to remember the main target for us will be histamine. The second target for us will be phospholipase A2. So the main medication, antihistamine. The second medication will be cortisone. And then we have the rest of the medication. Okay, last one here on the list, we have a medication black immunoglobulin, and this medication called omilozumab. And as you can see, here's the suffix mab. Mab stands for monoclonal antibody. Monoclonal antibody. So the omilozumab bind and block IgE and prevent IgE binding to the mast cells. Okay, so we're done with this one. With the previous one, I will go back. We need to remember this map here, what we have: mast cells, smooth muscles, what type of receptor, what type of enzyme we have. Okay, the mainstay of treatment, as we mentioned, corticosteroid. The mainstay of treatment, this is topical treatment, intranasal sprays. So we need to remember this one, local effect. This is the mainstay of treatment. This medication reduces inflammation, nasal inflammation. This topical cortisone in the same nasal will be combined with other medications such as antihistamine, for example. When you use this spray, that means we have minimal systemic effect. Very small amount of this medication will arrive to the systemic circulation. There is no risk of side effect. Intranasal cortisone, as you can see here, we have Flonase, like intranasal spray. We have Nasacort spray. We have list of medication: beclomethasone, budesonide, fluticasone, mimetasone, or triamcinolone. List of medication. The purpose of this, using intranasal spray, they found this medication reduce inflammation. This medication reduce release of mediator. This medication suppress white blood cells, especially neutrophils, suppress chemotaxis. This medication decrease edema. This medication cause mild vasoconstriction, inhibit mast cells mediated late phase. So inhaled cortisone considered like a magic bullet. It covers several variables: reduce inflammation, reduce mediator release, inhibit release of white blood cells, vasoconstriction, inhibit mast cells in late phase. And cortisone, for this reason, considered the most effective medication for the treatment of allergic rhinitis, because it targets several factors. This is number one. Number two, we need to take this in consideration. When you start using this medication arrives to the peak effect after 2 to 3 weeks time. So this medication need time. So if you prescribe this medication, we are not going to see the effect directly after 1 minute, 2 minutes, 3 minutes, 1 day. You need 2 to 3 weeks to see the peak effect. So the medication will start working, but after 2 to 3 effect, 2 to 3 weeks, 2 to 3 weeks, you see the effect of this medication. So this is the peak of the medication here. Okay. For this reason here, we can combine this, or we can start with the antihistamine to see the fast effect of the medication. So we start with antihistamine. We prescribe intranasal cortisone, because this one take 2 to 3 weeks to see the effect there. But some patients may suffer from nasal irritation as side effect, nosebleed, sore throat, we recommend to avoid deep inhalation during administration. As you can see here at the list again, this graph here shows the mechanism of action of corticosteroid. Corticosteroid inhibit enzyme called phospholipase A2, and this will lead to the inhibit the inflammation, chemotaxis, all these will be inhibited. Okay, we have beclomethasone, we have butazonide, we have fluticasone, memetazone. We have some systemic effect oral, but this one only for severe case. Please remember that we don't use it for regular rhinitis. For example, dexamethasone, we have methylprednisolone, we have prednisolone, we have prednisone. So we have list of medication oral, but it's not popular. This is for severe emergency, for severe and emergency case, but for regular use, for allergic rhinitis, go with the inhaler, nasal spray like beclomethasone, budesonide, fluticasone, cyclophosphamide, and other medication. Okay, again, how this medication work: decrease inflammation, decrease mucus production, decrease inflammation. What else here? This is important one, and this belong to the asthma, adrenergic. They found when you prescribe albuterol for asthma, for example, after maybe 1 week, 2 months, 3 months, 6 months, the response towards beta adrenergic agonist will be decreased due to something called tolerance. Okay, so they found when you prescribe cortisone to the patient take beta 2 agonist, this will improve response towards beta 2 agonist. Corticosteroid, I try to remind us that corticosteroid suppress the genes responsible for the pro-inflammatory cytokines such as TNF alpha, granulocyte, the interferon, interleukin, and other mediator. So we're done with the cortisone. Quick review for the corticosteroids. As you can see, the mainstay for the allergic rhinitis, corticosteroid. We can combine with other medications such as decongestant or like antihistamine. This, when you use it nasal spray, the systemic effect, the side effect will be minimal. How this medication work, we have different mechanism of action. As you can see, inflammation, the reduced mediator, and we need to take this in consideration. This medication need time to reach to take to 3 week. Okay, different name. We need to remember the mechanism of action, effect of the corticosteroid, the side of effect. Okay, moving to the next group of medication used for allergic rhinitis. This slide here to give us some maybe brief introduction to the pathophysiology for the histamine. Histamine released in response to the stimuli. Several receptors will be activated. We have histamine receptor 1, 2, 3, 4, but they said the most popular receptor will be histamine 1 and 2. This is the most popular one. We need to remember that histamine 2 mainly available, histamine 2 receptor mainly available in the stomach and responsible for acid secretion, and sometimes may cause peptic ulcer disease. It's not our topic today, but if you are interested, I refer you to see the lecture regarding peptic ulcer disease. Okay, what happened here? We talk about H1 receptor. H1 receptor responsible for the allergic reactions, and H1 receptor produced from mast cells, and you maybe you notice that from the previous slide. Okay, here we need to differentiate between two main things. We have smooth muscle cells. Okay, we have smooth muscle cells in the blood vessels. If the histamine receptor activated, so if the histamine receptor activated, the result will be vasodilation of smooth muscle cells. Vasodilation of smooth muscle cells. Okay, this will lead to the case called hypotension. Decrease, which means decreased blood pressure. Okay, what happened with the non-fiscular smooth muscle cells? The result will be contraction. Here we talk about bronchial tree. When we talk about nasal, about nose, about the eye, increased capillary permeability. So here we speak about edema. Okay, So when the histamine release may cause allergic rhinitis, may cause atopic dermatitis, may cause asthma, and we call this one dermatitis, allergic rhinitis, and asthma. Sometimes we see it in one patient. We call this one triad syndrome. So triad syndrome is a combination of three main diseases: allergic rhinitis, asthma, and dermatitis. Sometimes we can see allergic conjunctivitis. Okay. So this slide here explain the pathophysiology of histamine. When the histamine release, what is the effect? Histamine 1, histamine 2 receptor. We talk about what happened on the cell level, what type of disease will be involved in the histamine release, and then how we can treat the patient. Antihistamine, as you can see here, when you prescribe antihistamine, okay, you can see immediate effect. So here we need you to go back and look on the corticosteroid take 2 to 3 weeks to maybe to arrive to the peak of treatment. Here, when you prescribe antihistamine, this you can see the effect of this medication immediate. Could be like 30 minutes, could be 60 minutes, could be 2 hours. It depends on the case. Okay, so you can see the effect immediately here, like maybe after a few minutes or like 30 minutes, depends on oral or injectable here. So the patient will maybe suffer, maybe demonstrate relief symptoms of allergic reaction, allergic rhinitis also. So antihistamine available. We have two main. We talk about here oral antihistamine, and this is fast onset of action and useful for management of allergic rhinitis. Okay, by causing by histamine release, inhibit histamine release. Okay, more effective in the prevention of symptoms of mild or intermittent disease rather than treatment of the once the symptoms began. Okay, so here it's very important when you prescribe this medication. This medication prevent any further release of histamine. Okay, how we can look on this medication? They said, we try to remind us, we have first generation, then we have second generation. What is the difference? What is or are the differences between the first generation antihistamine, second generation antihistamine? First generation antihistamine, this medication able to cross blood-brain barrier, arrive to the central nervous system, cross blood-brain barrier, and this medication may cause sedation, decrease performance impairment, and may have anticholinergic effect. For this reason here, first generation is not very recommended for clinical use, but is available. We have diphenhydramine, we have dimenhydrinate, we have chlorpheniramine. Okay, not preferred due to the adverse effect, but is available. So, for example, if you have patients from allergic rhinitis and unable to sleep during the night, this is a drug of choice, because this medication facilitates sleeping, allow patient to sleep at night. But we don't recommend the patient to take this medication during driving, for example, or working on the heavy machine. So first generation, chlorpheniramine, dimenhydrinate, diphenhydramine, all these medication cause sedation, performance impairment, and anticholinergic effect. The preferred agent without these side effects, we have second generation, fexofenadine, loratadine, dosloratadine, and cetirizine. Better tolerated, less sedation, less effect on the performance, less anticholinergic effect. So we have two generations related to the antihistamine. Okay, antihistamine, we have generic name, we have brand name. As you can see here, talk about oral, we have nasal, we have eye drops, we have nasal spray. I will start with the oral. We have diphenhydramine, Benadryl. We have cetirizine, Zytric. We have loratadine, Claritine. We have foxafenadine. We have Allegra. We have levocetirizine, Zizal. We have bromethazine, Phenergan. Here we have the list of medication. Here we don't differentiate between first generation and second generation. But if we start talking about first generation and second generation, okay, diphenhydramine, first generation. I'll move chlorpheniramine, first generation. Bromethazine, first generation. That's nice. What about the second generation? Second generation, okay, for example, loratadine, second generation. Foxafenadine, second generation. Levocetirizine, second generation. Desloratadine, second generation. So we need to differentiate between first and second generation from this list here. Okay, eye drops, we have list of medication for eye drops. Okay, so I'm going to focus on the first three. We have ketotifen, we have azelastine, then we have olapeptidine. So for the eye drops, available eye drops, also available like nasal spray, both of them, azelastine, astubro, and we have olipeptidine. So olipeptidine, azelastine available for both. We can use it, both medication available for eye drops and nasal spray, but not the same brand name. So when we have eye drops, azelastine is different brand name. We have astubro for the nasal spray. We have different brand name for the eye. So we need you to differentiate between eye drops and nasal spray. Olipeptidine, azelastine, maybe the same generic name, but they have different brand name. Okay, so we have ophthalmic nasal antihistamine delivery devices available for topical tissue delivery here. Intranasal, as you can see, we have two medication. We already covered that. When you use it intranasal, that means we have less side effect, less systemic side effect. I will type here less systemic side effect. Sometimes we use combination with a decongestant to be more effective, especially if you have no response towards one medication. So we recommend to use this combination treatment. Okay, as you can see here, from this slide here, you can see olipeptidine nasal spray. Then we have olipeptidine here, eye allergy. Okay, then we have, for example, we have astubro. And astubro, if you remember, the astubro is like the name for the azelastine, and this one for the, you see here, for the nasal astubro. Okay, we're done with the antihistamine or antihistamine. Moving to the nasal decongestant. Nasal decongestant could be oral, could be topical. Topical is preferred because oral coming with a side effect. So if you use oral decongestant, here we talk about alpha 1 receptor antagonist, alpha 1 receptor agonist. And if you prescribe it orally to the patient, the result will be increased blood pressure, vasoconstriction. We don't recommend it to use it. So as you can see here, oral alpha antagonists, such as phenylephrine, for example, here, okay, activate alpha receptor, and this will lead to the increased peripheral resistance, increased blood pressure, and increased heart rate. We don't recommend to use it in patients with angina, for example, in patients with heart failure, in patients with hypertension. So oral, we don't recommend to use it. That's important issue here, but we take this in consideration if the patient totally healthy but suffer from common cold, for example. So what happened here? We go the topical alpha adrenergic agonist. This will lead to the constrict of the dilated arteries in the mucosa, and this will lead to the rapid onset of action and show few systemic effects. So I prefer to go the topical more than oral. So topical is the preferred, and you can see the immediate effect, quick effect, rapid effect with the improved symptoms here. Intranasal formulation should be used no longer than 3 days. Okay, so this is important issue here, that because what we have here, we are going to see some case called like increased risk of rebound nasal decongestions, because if the patient uses this medication more than 3 days, that means the patient will start depend on this medication, unable to breathe easily if you don't use this medication, and we call this one rebound nasal congestions. We call this one rhinitis medicamentosa. This is kind of rebound nasal decongestion that will be force the patient to keep using the medication for long period of time, and the patient become dependent on this medication. Okay, so what else here? Do you need to remember something else? Yes, we need to look on the duration of action. Okay, duration of action, we have category here for the treatment. We have 3 category. We have short acting, we have intermediate acting, we have long acting. Regarding short acting, one medication less than 4 hours, we have phenylephrine. So which of the following medication considered like short acting decongestant? Phenylephrine, 4 hours. intermediate acting nafazoline and tetrahydrozoline 2 to 6 hours. Which one long acting oxymetazoline and xylometazoline up to 12 hours. So as you can see here, we need to remember this category regarding antihistamine. We have short acting phenylephrine, intermediate nafazoline, long acting oxymetazoline. Okay, moving to the next group of medication. Topical intranasal mast cell stabilizer spray. Stabilizer spray, that means this medication will go to the mast cell surface, and on the mast cells here lead to stabilize the mast cell surface, and in this case will prevent release of granules, prevent release of histamine. As you can see here, this group of medication, cromolyn, sodium, inhibit degranulation of mast cells, inhibit degranulation, does not allow the granulation of mast cells, okay, and prevent release of mediator. That's fine. And they said no direct effect anti-inflammatory. This medication available as a non-prescription nasal spray, cromolyn sodium. Symptomatic prevention of allergy. So this one not for treatment, this one for prevention. Okay, so the only one slide, cromolyn sodium used for prevention. Moving to the leukotriene receptor antagonist. As you can see here, we have montelukast. Montelukast prevent action of leukotriene by mast cells and eosinophil. Help to control airway inflammation. So leukotriene receptor antagonist prevent inflammation. The most important issue here, different colored, bold, reduce inflammation in the upper respiratory system and the lower respiratory system. Here we start thinking about using this medication for asthma. We use it for allergic rhinitis. Okay, consider when oral antihistamine and intranasal cortisone is ineffective, not tolerated, especially if we have patients suffer from asthma and allergic rhinitis. If we have children, for example, suffer from asthma and allergic rhinitis, montelukast will be the drug of choice for this patient. So children with the asthma, allergic rhinitis, this will be a great choice for the patient. But speaking in general, for the allergic rhinitis, montelukast is not first choice. Montelukast is that could be third line treatment. So for allergic rhinitis, first choice will be inhaled or intranasal. Okay, cortisone, corticosteroid, or antihistamine. So again, leukotriene receptor antagonist, consider like when antihistamine and cortisone is ineffective or not tolerated, and especially if the patients are from asthma, very effective in children. Ipratropium like intranasal, again, to remind you what is ipratropium, is like muscarinic receptor antagonist. Someone may be confused, what is ipratropium? Muscarinic receptor antagonist, that mean this medication bind to M3 receptor. If you say this one like M3 receptor here, and our medication ipratropium will bind to the receptor and block the receptor. Okay, it's muscarinic receptor, muscarinic blocker. Okay. And if you need to remember more information here, we have Ibra, then we have Trop. Trop stands for tropine. So this one derived from atropine. Ipratropium. Okay, this available like nasal spray. You can see the image here. Nasal spray as anticholinergic agent. It's not included in the current treatment guidelines. So it's the current treatment guidelines. We don't have ipratropium. We don't use it. We don't recommend. We have other priority. We can start with the antihistamine. We can start with the cortisone. We can start with the decongestant. We can go with the montelukast. Okay, what happened here with the some maybe information regarding the Montelukast. Shall we use Montelukast? Should we prescribe Montelukast to allergic pediatric patient? Here, this article from Literature Review 20 published 2020. Should we prescribe Montelukast to the allergic patients? Intranasal steroid is a primary. Intranasal steroid is a primary, maybe recommended for allergic rhinitis. But for patients who cannot use intranasal steroid, loratadine receptor antagonist alone or combination may be recommended. So here we need to remember that. If the patient on cortisone, antihistamine is not enough, maybe cannot control symptoms, the alternative will be loratadine receptor antagonist. Again, useful in treatment of rhinitis and asthma. Here we talk about children. Okay, what about oral? Shall we use cortisone oral? They said yes if we have severe symptoms, but irregular, we don't recommend to use it due to the side effect. Okay, we don't recommend to use systemic. We don't really recommend to use oral. Please remember that. Because if you use oral or injectable, this will lead to the osteoporosis. This will lead to the diabetes. This will lead to the increased blood pressure, edema, cataract. So we have so many side effects coming from the cortisone. We don't recommend to use oral, but we can use it only for severe cases and for limited time. Okay. Okay, this may be information derived from the e-medicine, Medscape, regarding the allergic rhinitis pharmacotherapy summary, and recommend to read it at. This will conclude our lecture for today regarding allergic rhinitis. We cover the antihistamine, we cover the cortisone, we cover loratadine receptor antagonist. We cover the cholinergic antagonists such as Ipratropium. We cover the beta-2 agonists such as albuterol. All these medication, cromolyn, sodium, for example, to prevent allergic rhinitis. At the end, we would like to thank you for your watching and have a great day, everyone.